In 1999, a 14-year-old girl of Turkish origin presented with vertigo and generalized tonic-clonic seizures. Magnetic resonance imaging (MRI) analysis showed multiple hyperintense lesions in T2-weighted images, bihemispheric paraventricular white matter, frontal cortex, left insular cortex, left brainstem. A symptomatic treatment with valproate was initiated. In 2002, 3 years after onset of central nervous system (CNS) inflammation, a mild thrombocytopenia, 110 × 10 to the third cells per microliter, occurred for the first time, but no further diagnostics were carried out. In the next years, she experienced various neurological symptoms such as hypoesthesia, weakness of her right arm, vertigo, and double vision. These relapses occurred in a frequency of 1 to 6 events per year. MRI analysis showed a slow progression of inflammatory gadolinium-enhancing (GD+) lesions, mostly localized in subcortical and periventricular areas, Figure 1. Conventional angiographies 2004 and 2008 revealed no signs of vessel stenosis, sinus thrombosis, or other signs indicative of primary CNS vasculitis. Under the assumption of a relapsing remitting multiple sclerosis, these clinical symptoms, as well as future relapses, were treated with intravenous steroids until 2011. After our patient's first presentation to the clinic in 2011, an extensive clinical reevaluation was performed due to increasing doubts concerning the initial diagnosis of multiple sclerosis. Analysis of cerebrospinal fluid, CSF, showed lymphocytic pleocytosis, intrathecal synthesis of IgG and IgM, impairment of blood-brain barrier integrity, and positive oligoclonal bands. A differential diagnosis, including serological, microbiological, and virological analysis from both her blood and CSF, revealed no signs for a systematic vasculitis, infection, or any underlying specific autoimmune diseases. After another relapse presenting with unsystematic vertigo, we ultimately clarified the nature of her inflammatory leukoencephalopathy by performing a brain biopsy. This showed severe perivascular inflammatory infiltrates as well as diffuse cellular infiltration within the parenchyma. The infiltrates were dominated by small mature CD3 plus T cells and high numbers of CD138 plus plasma cells, whereas only low B cell numbers could be observed. A diagnosis of Evans syndrome, ES, is a rare hematological disease commonly defined by the combination of simultaneous or sequential autoimmune hemolytic anemia, IAHA, and immune thrombocytopenia, ITP, sometimes associated with neutropenia, in the absence known of underlying etiology. Based on the detection of CD20 plus B cells and CD138 plus plasma cells, both by flow cytometry assessment of her CFS and by immunohistochemical stainings, we initiated treatment with anti-CD20 monoclonal antibody rituximab. This treatment regime could be beneficially used in CNS inflammation and has already been reported to be effective in cases of ES. Prognosis: Evans syndrome.